In November 1906, a German psychiatrist presented a 1.5-page report describing a single dementia patient. 7 months later, a rival clinic published a comprehensive monograph detailing the exact same pathology across 16 brains, eventually expanding their dataset to nearly 300. Today, the disease carries the name of the man who examined one patient. That comprehensive monograph belonged to Oskar Fischer. Working with a dataset that would reach 275 brains, Fischer mapped a population-scale chronology of the disease. He stratified his subjects, established taxonomic control groups, and isolated distinct clinical variations of dementia. Alois Alzheimer's advantage was not empirical priority. His advantage was institutional geography. Alzheimer operated within Emil Kraepelin's psychiatric establishment in Munich, the clinic that dictated clinical standards across continental Europe. Fischer, by contrast, worked out of Arnold Pick's clinic in Prague. The Prague school prioritized morphological description and clinical correlation over the cult of personality that defined the Munich establishment. In 1910, Kraepelin published the 8th edition of his textbook, the definitive field-making text of European psychiatry. Inside it, he explicitly named the pathology Alzheimer's Krankheit, securing the disease for his own colleague and stamping Munich's ownership on the pathology. Kraepelin's textbook entry excised Fischer's data. It ignored his 8th-stage chronology and his observations of the disease in the cognitively normal. The medical canon absorbed a highly truncated, single-case version of the pathology. Medical eponyms install structural explanatory templates. By absorbing Munich's frame and discarding Prague's, neuroscience locked itself into a static, single-cause interpretation of the disease for the next century. We see this most clearly in the language we inherited. The defining feature of Alzheimer's disease is known as a senile plaque. The word plaque describes a passive deposit, a residue, or a sediment. If the defining lesion is a passive deposit, the logical scientific question is to ask what is precipitating. This language birthed the amyloid cascade hypothesis, forcing generations of researchers to target the accumulation of protein rather than asking why the surrounding cells were failing. Fischer rejected the term plaque. He proposed the name spherotrichia cerebri multiplex, which translates to a multiplicity of radial fibrillar balls. Spherotrichia is the vocabulary of active morphogenesis. It describes a structure that grows, recruits surrounding tissue, triggers necrosis, and possesses a defined chronological lifespan. Naming the disease for Alzheimer's stripped the field of the active morphogenetic vocabulary required to investigate why the disease occurs. This 1910 illustration maps the lesion into 8 developmental stages. The pathology was a sequential process. It starts with the morning star phase, evolves into an early druze, triggers necrosis, and draws in microglial cells. It terminates in the ghost plaque stage, a burnt-out scar. Because Fischer possessed an 8-stage map of the lesion's life cycle, he was able to make a specific empirical observation. He identified the earliest stages of these lesions in the brains of elderly individuals who possessed completely normal cognitive function. Finding early-stage pathology in healthy patients proved that the disease begins its biological timeline decades before clinical symptoms of dementia manifest. Modern neuroscience formally articulated this preclinical concept using advanced biomarker frameworks in 2011. Fischer published the empirical groundwork for it a century earlier. Had the field inherited Fischer's chronology in 1910, longitudinal trials targeting the early preclinical stages would have been the default research design by the 1980s. The discipline could have avoided decades of negative drug trials aimed at patients in the terminal stages of the disease. The Munich School's framework focused on the passive amyloid core of the lesion. Fischer's chronology focused heavily on the surrounding axonal failure. This 1910 illustration shows Fischer's documentation of dystrophic neurites, club-shaped extensions radiating from the lesion's center. Fischer physically counted these across his samples. He documented that they clustered exclusively during the middle, highly active stages of the disease's evolution, disappearing as the lesion burned out. Contemporary researchers are currently advancing the inside-out and Panthos models, suggesting the disease stems from intracellular autophagic lysosomal failure, where neurons fail to clear their own waste and burst. This modern fluorescence microscopy shows the exact same pathology in mouse models, highlighting dense core thioflavin S deposits and IBA1-positive microglia infiltrating the cellular failure. This 2024 imaging of microglial infiltration perfectly matches the structures Fischer documented engaging the spherotrichia over a century prior. Modern research has arrived at the axonal lysosomal framing Fischer established in Prague, confirming his 1911 observations with 21st century tools. The contemporary understanding of autophagic failure is the consequence of finally examining the disease through Fischer's active multicellular lens. Fischer's academic momentum steadily eroded through the 1920s and 30s. However, his existential base was the Welleslavine Sanatorium, a working psychiatric clinic he co-owned and built. On March 15, 1939, German troops occupied the remaining Czech lands. For Jewish professionals in Prague, the survival calculus altered overnight. Exactly 48 hours after occupation, Fischer executed a legal maneuver to protect his life's work. This March 17, 1939 document outlines the transfer. He transferred his half of the property to his non-Jewish wife, reserving only the right of usufruct to continue practicing medicine. The Reich retroactively voided the transfer. The clinic was seized and forcibly sold to a convicted Abwehr double agent. The purchase funds from the forced sale were deposited into a blocked account. The occupying administration then used that money to finance Fischer's own deportation to a concentration camp. Fischer was not swept up in a general arrest of Jewish professionals. According to the written testimony of a fellow prisoner, the Gestapo arrested Fischer specifically because he refused to sign the forced sale of his clinic. The archival record shows he was sent to the police prison, separate from the general ghetto. On this postcard in his own handwriting, he lists his location as the Kleine Festung, the small fortress, cell 7. Independent records, eyewitness testimony, and a post-war state certification confirm that Oskar Fischer was tortured and beaten to death by the Gestapo on February 28, 1942. The Munich school did not kill Fischer, and the Gestapo had no interest in his scientific theories. But sequentially, the stolen epidem and the stolen clinic ensured the total removal of his biological framework from living memory. By adopting the Munich single-cause model, Alzheimer's research fractured into highly isolated communities: amyloid, glial, matrix, and neuroadrenergic, operating with zero overlapping data flow. Funding pipelines, specialized journals, and rigid grant priorities reinforced these walls, preventing cross-disciplinary communication. Fischer's 1907 spherotrichia model was inherently anti-silo. Because it mapped an integrated cellular ecology, it required all of these disciplines to work together to understand the morphogenic chronology of the lesion. The high failure rate of Alzheimer's clinical trials is a structural consequence of losing the integrative vocabulary required to view the disease holistically. Modern initiatives, such as the Oskar Fischer Prize, are pivoting the field back towards taxonomic pluralism and active morphogenesis. Restoring Fischer's name to the technical literature represents a commitment to the integrative science his work once supported.
We are looking at a dual tragedy: an intellectual framework eclipsed by institutional gravity, and a clinician murdered for his property. Effective intervention in Alzheimer's disease depends on shifting focus away from the passive plaque to address the active multicellular process that was buried in a Gestapo prison in 1942.